Welcome to Health IQ. I'm Dr. Alan Siegel. Today we have a special guest, Dr. Elan Goldwaser. He's with Columbia Orthopedics. He has offices in Scarsdale, Tarrytown, and Manhattan. He's an interventional sports medicine physician. Welcome, Dr. Goldwaser. How are you doing?
Well, thank you, Dr. Siegel. Thank you for having me. I'm feeling pretty good.
So tell us about what is an interventional sports medicine doctor and what made you choose that particular certification and your background as an osteopath.
Absolutely. So the reason I chose to become an interventional sports medicine physician rather than surgical or even conservative is because I found that with a lot of our athletes, we can get them better quicker than we could have in the past. We may not need to do surgery necessarily on a lot of our patients, and we may be able to offer them more than just telling them to rest for a while. So what is that gray area in between? And that's that interventional aspect of a sports medicine physician. A lot of the procedures I offer are minimally invasive with regards to needling or injections or even introduction of different kinds of techniques to work on the athlete's own form and posture to help them improve their own way of doing things in sports to get better faster.
So a lot of times as a sports medicine doctor, people come in with a pain or swelling or an inflammation or some kind of area that bothers them. A lot of doctors, as you may attest to, sometimes will just kind of micro-focus on that particular spot or that particular area. But we know, especially if you have an osteopathic background, I have a chiropractic background, we tend to like to look at the body a little bit more as a whole. Just to kind of describe how you do assess an athlete or, a weekend warrior or just the average, mom and dad at home that are having a particular problem. It could be from too many chores around the house or whatever it may be, but it may not be related from that one particular problem, but it may be a global issue for that person, right?
Absolutely. Well, athletes do come in all ages and shapes and sizes, and it's funny, today we just had someone 97 and she tango dances, and she came waltzing into the room and said, "Can you shoot at my knees so I can get back out there?" So, it may not be the Olympian, but everyone's an athlete in their own way, and that's kind of the mentality I took from medical school as an osteopath when I went to osteopathic medical school. And part of the reason I went to that route was because I looked at the philosophy of how they look at the patients and kind of see, well, here's your injury, but where's it really coming from? Yeah, you have knee pain, but is it your hip or is it the way you're doing things? Is it your foot, your shoe? What about your way of living is causing your ailment? And that's I thought that was an interesting focus and why I chose to go into an osteopathic route. As it comes to sports medicine, I thought it fit like a hand-in-glove type situation in terms of the manual therapy we learn in the osteopathic medical training and how applying that to sports ailments, we can get athletes to kind of rebalance their muscles, rebalance their bone structure, realign them, and get them back to moving the way they need to.
So a lot of injuries that you see probably kind of a cause and effect, whether biomechanics are off or whether there's some structural problem with that patient, whether it's a muscular imbalance, a postural imbalance. So you look at that collectively when you're looking at your patients to try and correct the issue, right?
Absolutely. Postural imbalances are way more rampant than we assume. Everybody comes in with their own unique form and function that follows it and their own structure and alignment. A lot of times those alignments are off. And it's funny, a lot of times we don't realize, am I walking a little weird or is my balance off? A lot of times that comes down to, well, where along your skeletal structure have you fallen out of place? And our job in the sports medicine community is not only to diagnose the problem, but to see where it's coming from. And so with me, when I have athletes come in, we take a look at, the way that their feet sit on the floor and if there's a little rolling in of the arches, or we take a look at the knees and see.
Like pronation, people call like a pronation.
Absolutely.
Flat-footed or different types of foot problems that can cause like inverted knees.
When we have flat feet, what happens a lot of the times is the whole leg turns in towards the floor to follow that arch. And many patients don't realize that's what's going on when they come in with knee pain, and they're wondering, why is there pain around my kneecaps, especially athletes after sports? A lot of times athletes come in and they say their knee hurts. And when I ask them, well, where and why, and is it when you go up and down stairs, is it kneeling, squatting, and after athletics? A lot of them look at me and they say, how'd you know know all of that. And it's because it follows the mechanics of how they move. And if their foot is collapsing, their knee is kind of putting a lot of pressure, the cartilage in between the kneecap and the leg bone, and causing a lot of irritation. But it doesn't always have to come from the foot. A lot of times athletes can be imbalanced in the hip, and I often see that through weaker core and weaker hip musculature, you get a lot of this collapse of the
like gluteal musculature or psoas, things of that nature.
Absolutely.
People hear those
and
terms
even
all
the
time.
muscle, the piriformis.
Right.
All of those muscles form the gluteal complex. There's a whole slew of them, like 7 or so muscles, kind of like the rotator cuff of the hip. When one of those muscles is a little off balance, the rest of the hip cannot, it kind of falls to the wayside, and you see the hip actually collapse. And so we can look at that and really tease it out in the office and say, the reason you're having pain in this area is because you're weaker in this area. And it's a spectrum of biomechanical instability, I call it. And that instability comes from select muscular weaknesses because we don't focus on those in particular sports.
Now, would you use orthotics for patients sometimes, or recommend them based on if it is truly a foot problem that's at least causal to some of the issues? It may not be the only problem. But.
Well, that's absolutely, I mean, that's a good question. And you would, but a lot of times orthotics, it's not the full answer. Custom orthotics are great. But do we need custom orthotics? I'd say the technology these days, we don't. You can buy over-the-counter inserts. There's several different brands that, and you can compare them to custom-made orthotics. It's the same thing.
It's negligible, right?
Yeah, and I'll tell you what, I've run marathons in custom orthotics, and even in inserts, there's no difference.
Right.
I mean, it's all about aligning your arch, but that's just a piece of it. It's also about building up the strength of your hips. When we have athletes with weaker hips, if they get stronger there, the rest of the leg falls into place. So it's usually a combination of correcting the alignment with equipment, but also building up an internal strengthening so that they don't.
So it sounds like your background fits in very well with the physical therapy, rehabilitation, specialists as well. So I'm sure you work with very good specialists, and you refer out for other areas. But it sounds like that combination of rehab and assessment is really important, and you being able to kind of diagnose where the issues are and then have someone follow a specific protocol, rehabilitation protocol, to strengthen those areas that need strengthening, possibly stretch the areas that need stretching. So there's always like in a protagonistic, antagonistic world, but sometimes not everyone knows exactly what to do.
No, that's a great point. And I work very closely with all the physical therapists in the area. Physical therapists, chiropractors, even acupuncturists. There's a lot of different modalities, and I think the general philosophy is no one should ever discredit one other way of working on somebody because everybody responds differently. So I work very closely with a lot of the area's physical therapists through email, text, phone calls, and we decide what modalities work best for different patients, and we hone in on that to help them get better.
Now, for repetitive stress injuries, or like your more common injuries that you see as part of your interventional sports medicine, I mean, there are so many injuries out there, but you got your golfers, you got your tennis players, you got your basketball players, hockey players, and I guess it depends on the age, but what are some of the more common things that you kind of see on a day-to-day basis?
Absolutely. Well, it depends on the age group. So, a lot of times we have, some of our college and even professional people that come in, they complain that they're having these vague type pains, pinpoint on the bone in different areas, and you wonder, okay, well, what's your training regimen like? And way too often I hear, basically in not so many words, I'm doing too much, too soon, too fast. And by ramping up your training too quickly, you're going to overload the joints, overload the muscles, and you're going to start to break down. More important than the training aspect of things from an active standpoint is the inactive, passive, resting standpoint. And a lot of athletes don't quite grasp the need for rest. But that aside, because that's a whole nother conversation, yes. Is the idea that repetitive stress injuries, when they come in, can be managed interventionally. And we can get people feeling a little better and sooner back to sport.
And we're not going to get too into it, but we know youth athletes, we have a problem with overworking these kids and
sports specialization
and not resting them enough and having them do the same thing over and over and over again. And we know what's happening out there. I think I've spoken about it on other shows, but it's just parents have to understand that you have to look at your kids' best health interest long term. and having some of these injuries at a young age is not really the path we want to go down. You know?
It's hard. Multiple sports, it's the way you really build athleticism. And I was talking to a physical therapist once when I was out in so I was out in Japan a few weeks ago, and before things went haywire, and I was covering one of this high-level World Cup event, and the physical therapist with me out there, we were talking about the athletes that we were working with, and we looked at each other and said, you know what? A lot of these athletes train their entire lives in one sport, and when they get injured, they don't know what to do, and they decondition, they stress, they become anxious. But a lot of times, it's about teaching the athlete that athleticism is more than just a sport. It's learning how to be an athlete in all sports.
Right.
And I think that's something we need to instill in youth at a younger age.
Yeah, I like to use the word planner, where kids are jumping and moving in all different directions, doing different things in different, vectors, front, backwards, up, down, left, right. Like when we were kids, we just ran around and did all these different things. Nowadays, these kids aren't doing quite as much when they're not doing their sports, and I feel like that's surely not good for them. But well, that's a whole that's
right,
a youth
exactly.
athletic program. But I think that we made the point that let your kids do a little bit of everything. Let them train a little bit. Generally speaking, let them just go outside and run around.
And studies show it makes them a better athlete in the future in the sport they differentiate into.
Yes, and I would agree with that. So I would think like tendinitises, bursitis, all different types of
super common,
common inflammatory issues, patellofemoral syndrome for maybe your runners out there. How do you kind of work with those patients? And if you want to discuss some of your more interventional treatments, talk about like if you're doing some PRP and explain what that is, because I think there's some confusion in the world as to what some of these procedures are.
In the world is right. So what are those kinds of treatments and what are they good for? So you mentioned a few ailments, we'll call them. So, treating different issues requires different approaches. When it comes to patellofemoral syndrome, the most important part to me is the biomechanics, what we just talked about, looking at how the athlete stands, moves, how their alignment is. Because patellofemoral syndrome, while a brace is great, they can fix themselves with the right physical therapy. But things like tendinitis, yes, if it becomes chronic, that's more of an issue. But the main piece of the tendinitis treatments, aside from correcting their postural mechanics and instabilities, is helping that tendinitis heal. Having a tendon that's inflamed for a while, we try to calm that down. The old thinking was, let's use steroid. Let's just blast it with steroid because you know what? Steroid's like a hose to the fire. It's the wrong way of looking at it because steroid can weaken tendon, it can weaken bone.
It can degrade tissue, basically.
Degrade cartilage, exactly.
Yes.
And so, what is steroid really good for? We make it within our own bodies, just not in the amount that we inject with. Steroid does have its uses. We calm down a lot of acute flare-ups with that. However, there's more and more studies showing that there's probably safer alternatives. What are those safer alternatives? So when we look at people with chronic stress issues, ice packs. Everyone gets an ice pack. So that does help. But how do we do that faster? So we put that ice pack under the skin with the use of something like biologic treatments. What are orthobiologics, quote unquote? It's a hot new field of injectable medicine that comes from you. So there's a big appeal to it because we can use your body's own material after we process it a little bit. We can inject it in, and that can help boost the healing response significantly. Now, the big controversy behind all of these different things is that there's, everyone will say there's no evidence, quote unquote. There is evidence. It's just a little wishy-washy. Some of the older evidence that has accumulated about a lot of these biologics has been negative for the most part. But a lot of the newer studies are showing a lot of promise with these sorts of things. Now, let's talk about what things biologics are. You mentioned PRP. So platelet-rich plasma, or PRP, is a material we obtain from drawing your blood from your arm, spinning it down in a centrifuge, and then it leaves a thin layer in between all of the layers of blood and plasma called the platelet-rich plasma layer. It's a thin layer in between, and what we can do is draw that out, and it contains a lot of platelets, growth factors, the materials the body uses to scab things over and heal. We can take that and inject it into a hot area, a tendinitis type area. And by putting that around an inflamed area, we can get it to heal through the body's own means.
What about tears? I know you mentioned tendonitis. What about like more of a micro tear or a small tear? Could that be
now helpful? Let's talk semantics. Because tendonitis is a tear, but not necessarily the tear that we're thinking of in our head. We have different grades of tendonitis. We have grade 1, which is a little irritated. Grade 2, where there's a partial tearing, where a piece of that tendon has peeled back a little bit from being overly worked and pulled
like
a little too hard.
Rubber band, I like to
exactly.
That, yeah.
A frayed rubber band, that's a good example. And then grade 3, that rubber band snapped. It's totally separated. Those usually require surgery. Usually. However, grade 2 tendonitis or partial tearing, those can heal by other means. Yes, we can put them through physical therapy, but what if we can do it with physical therapy and make them heal faster? And the promise of biologics is that we can inject these materials into the body to help heal and bridge back together that partial tear, or at least prevent it from getting worse and heal up the piece that's still there. So let's talk more about the different options. So platelet-rich plasma has been around for about 30 years or so. It's been refined since through different machines and different kinds of protocols, and it really helps to kind of deliver growth factors that induce the body's healing mechanisms through inflammation. A couple days of inflammation at the site of the injection, and then as that calms down, the body signals to heal it. Other biologic materials we utilize too, if we go in succession, are...
Well, before you go on,
yeah, of course.
So just to support your PRP treatment, quick little story. So my mother, who had multiple hip surgeries, on the same hip, she had a hip and then a hip revision. She was having a lot of gluteal pain, like lateral gluteal pain, and the doctor, and then she had spinal surgery. So there's a lot of things going on, a lot of layers of it. So no one could figure out where the pain was coming from. And I kept looking at the MRIs, just as a son would, and they kept saying glute medius tear, glute medius tear, glute medius tear. The problem is none of the doctors were paying attention to the glute medius tear. They were all paying attention to everything else that looked worse at the time or seemed worse at the time, and injecting, the spine, injecting them so I told them, I said, why don't we look at where she's complaining about? They pinpoint, they put her thumb right in the glute medius, and she would jump off the table, right? So I'm like, that's probably your spot. I suggested that they do the PRP. She did 2 treatments on the PRP, the glute medius tear, and she did much better. So
that's fantastic.
So it is like you say, evidence-based. Yeah, evidence-based is only how much money and how much research has been put into something.
You couldn't have said it better, yeah.
It doesn't always mean that it doesn't work or it shouldn't be tried if it's safe and effective and it do no harm, right? So there are a lot of procedures out there that may not have evidence-based. There's a lot of things in this world that are not evidence-based, but we know they work.
Steroids not evidence-based.
Exactly. So,
and what does that say?
So evidence-based is about how do we get drugs to the market quicker, and so there's a whole other show for that too. Yeah. But I believe in some of the procedures that you guys are starting to do, like the PRP and whatever we're going to talk about next. They're very important, and they are the next step in sports medicine, in my opinion.
Exactly, and it's hard to say that. It's hard for me to get people to endorse an anecdote-based type situation. However, there is a lot of great evidence coming out. Now, PRP is a fantastic modality, and it does require, as you've mentioned, a couple of them. Some people do well after 1 injection, but it usually does require 2 to 3, spaced apart, of course. Now, we're still figuring out the right protocols, of course, but aside from knowing that we need multiple PRP injections, what's the next orthobiologic material that we can use that's more potent? Well, we also have the ability to inject placental tissue. Now, that sounds crazy, right? So we take donated placentas from mothers who have given birth, and we can dry them out or desiccate them and irradiate them, which means kill all the cells. So we're left with powder, this pulverized kind of small little vial of powder. That powder contains a ton of proteins. All these proteins and growth factors that exist in this vial, there's like 220 of them or probably more. It's a lot more than PRP would have. However, the trade-off is there's no cells in them, meaning there's no platelets. Those platelets help with the clotting kind of situation to help keep those growth factors in place. But the nice thing is you only have to do 1 injection of the placental tissue, or what we call dehydrated human amniotic membrane. It's a mouthful.
Are these would they be stem cells, or this is not exactly stem cells?
No, that's a great question, and I'll be very clear.
Confusion in the world as to what a stem cell
very, very clear. There are no stem cells in amniotic tissue, ever. In the U.S., it is just proteins. However, if you go to Europe, you might find something different. But that I highly discourage, because you never know what's going to grow out of that. And there's been case reports of crazy tumors starting to grow from placental stem cells being injected into people. So that aside,
okay. So we'll stick to the U.S. version.
Yes, exactly. And while placental tissue has its place, it is a little liquidy. Like I was saying, PRP is very sticky. It holds the tear together, and it can help kind of bridge back a little bit of that tendinitis. So moving on to one of the more potent and kind of the crown jewels of the biologic realm is the idea of quote-unquote stem cells. Those can come from bone marrow, and those can come from fat. There's different reasons why you would pick one over the other. Some of it has to do with, do patients have fat? Or some of it has to do with...
Are these harvested from the patient or from other people?
Very good question. It comes from the patient. Remember, so biologics means it comes from your own biological material, with the exception of the placental tissue, of course. However, stem cells, when we harvest them, they're very potent in their efficacy to treat. But what are we really harvesting there? A lot of the big debate is, are they even stem cells? And we'll go into arguments all night long with different physicians and behind closed doors about what are we really injecting, and we're doing so much research to try and figure it out. The truth is, these stem cells aren't really stem cells. They're medicinal signaling cells, or cells that call the body's stem cells to that site to start up the healing process. There's a lot of fancy names. We've heard exosomes, we've heard metalloproteinases. It doesn't matter.
They get the party started.
Exactly. Actually, that is an excellent way to put it. They get the party started. So, one of the things I like to do is consider when there is a tendinitis coming in, and these are athletes that need to get back to sport, and they're like, I can't wait any longer. I have whatever coming up that's high level that I need to be participating in. That's when we dip into the biologic realm. Of course, physical therapy is always involved, but we decide at that point, what would they benefit most from? Is it PRP? Is it, the dehydrated human amniotic membrane? Is it these mesenchymal signaling cells? That is an individualized discussion, because there's a lot of pros and cons to each one, but we're still trying to figure out the best protocols for each material.
I think condition-based is always like one of those things, like people hear like common injuries, meniscal tear. Like everyone thinks they either have one or know someone that has one, and they want to know, okay, do I need surgery on a meniscal tear? And then, even evidence-based, when you talk about evidence-based, they do studies and studies and studies. Does every patient have a meniscal tear need a meniscal surgery? And the evidence is sometimes even
a little wishy-washy,
right? So can any of these types of procedures potentially help with cartilage type issues, whether it's osteoarthritis or a tear or a joint degradation of the hip, again, osteoarthritis of the hip, possibly even the shoulder?
So with all of these big joints, and when it comes to arthritic changes, there's some good evidence that PRP actually does postpone any pain for upwards of a year, sometimes even longer, in a similar fashion to other injections like those gel shots, viscosupplementation. So if that's the case, why use something else when you can use your own material if you're going to get just the same efficacy with it? Will this heal back cartilage? That's the holy grail of what biologics look for. Well, we haven't found any strong evidence that, yes, cartilage can regenerate from this material. There is some promise, but it's going to take a lot more studies, a lot more evidence, and a lot more trials to see if we can grow back what's lost and reform the bone that's taken decades to develop bone spurs and arthritis. And how do we reverse that? We're still looking.
Yes.
But I will say the biologics
But it
help.
seems like that's kind of like the goal. Like that's where some of these advanced medical technologies are going towards. Looking at less surgeries, less joint replacements down the road, or trying to be more, like you use the word interventional. Someone starts with mild to moderate osteoarthritis. How do we prevent it from becoming severe,
worse, right?
Debilitating osteoarthritis?
Well, I will say there is a material we use in the office called alpha-2 macroglobulin. Don't remember that. A2M is a big protein that exists in your blood that kind of halts the progression of arthritis. It takes those inflammatory markers and stops it. We've started using that in the office on our patients with mild to moderate arthritis, and we're noticing some great results. Patients are able to get out there and run and move and not have that achy pain that they were dealing with. How long it lasts? Well, this is a very new type of...
This is totally different than Synovisc and Orthovisc and all of those.
Yes, this is... So alpha-2 macroglobulin...
jobs, kind of.
Exactly, yeah. No, this is like we draw it from your blood, we spin it down in a centrifuge, and then we run it through this crazy chemistry set like you would imagine in like high school chemistry, and we get out this like protein. And that protein we can inject into the joint space where it's too big to have gone into from the bloodstream. And then it sits there and it continues to stop the progression of arthritis. And that's the promise and the science behind it. And now we're collecting data. So we've noticed some good things with it. Some people are doing pretty well with it. And in addition, a lot of the biologics we've been using, even if we're not growing back cartilage, I guess the main point of the orthobiologics is that almost everyone has had relief. And that, to me, is more important.
Yeah, well, it is case-based, evidence-based to some degree. I mean, there's different levels of it, but I think that gives you, as a sports physician, enough firepower to be like, hey, look, this is working. This is preventing you from having to take, NSAIDs and opiates and things of that nature, because we know that historically those have not done our society well over the last
And I'll tell you
decades.
Fun fact, anti-inflammatories do kind of degrade the cartilage over time. So when I have people come in saying they're thinking of pre-medicating with 800 milligrams of ibuprofen before a marathon, definitely I tell them not to, because of that risk. Well, it will start to degrade the cartilage a little bit.
Right. Well, with that being said, nutritionally speaking, I'm sure that's maybe not a big part of what you do, but I think it's probably something you're interested in. I'm sure there's a lot of things that people can put in their bodies that are maybe more on the anti-inflammatory range, can help, just generally speaking, with overall health.
Absolutely.
And
well, I'm glad you brought that up, because I do counsel people on nutrition in the office all the time. It's funny, I never saw myself as a nutritionist. I don't even feel like I can have the validation to or impetus to do it. But in any case, I always talk about anti-inflammatory diets with patients because it helps a lot of people. Eating more garlic, turmeric, black pepper, ginger, those kinds of things, capsaicin, they are anti-inflammatory in their own properties, and they can actually help kind of calm down a lot of the inflammatory pain that these patients are feeling.
With no side effects.
With no side effects. With a change in diet side effect. But, a lot of people never regret it. And there's anti-inflammatory diets online. I tell people to follow this stuff all the time. And people come in feeling better after going through it for a little bit.
Yeah, I think there's got to be a commitment, both on the patient's side and the doctor's side, to come up with what I would call like conservative, minimally invasive sports medical care, slash, everyone thinks of orthopedics as surgical, but truth be told, most patients that even do see surgeons end up maybe not having surgery unless they're already a true candidate for surgery or they had a significant trauma. Those are different scenarios. But like sports medicine stuff, if you, like you said, if it's evaluated and treated properly, probably like 70, 80%, maybe even higher, can be treated somewhat conservatively.
Oh yeah, I've even seen numbers up to 90% of orthopedic issues do not need surgery.
Yeah.
But you're right, you harped on an interesting point there, that this needs to be a partnership with the patient and the physician and a discussed and shared plan. It'd be one thing to just rattle off some orders to a patient and walk out of the room. They'll never understand it. I take the time to talk to those patients because it matters that they get what they need to do. And a lot of these athletes are motivated.
Right. Well, look, I think our audience, if they got anything out of today's show, I think what they should understand is that, number one, there are board-certified sports physicians like yourself who can really manage and assess a multitude of conditions, musculoskeletal in nature, sports in nature. Like you said, we're all athletes, whether we're 90 or 12. And I think you work with pediatrics up to elderly, and I think everyone is unique. So assessing them in that unique fashion is really important. And know that they can have a conservative approach to treating them, knowing that they'll work with your physical therapists and your acupuncturists and your chiropractors to correct imbalances, musculoskeletal imbalances. We're running a little bit shy on time today, but I know you work with concussion as well. It's a big hot
Absolutely.
topic.
We'll have to talk about that sometime.
Concussion management and working with whether it's pediatrics or adolescents or whomever, because a lot of times it's more complex than people think it is, especially if they're not healing well, and what are some of the protocols you can do to conservatively manage those cases. So I think that's a great thing. So I want to thank you for being on the show.
Of course. Thank you for having me, Dr. Siegel.
And I want to thank everyone for watching Health IQ. And if you need any information for Dr. Goldwaser, so come up on Columbia University's website. And again, he's here in Scarsdale, Tarrytown, Westchester, and in New York City as well. So thank you very much. Have a good night. We'll see you next time. Bye-bye.
Thank you.